Hi, everyone. We're going to get started with the next session. It's on systemic therapy and the progress that we're making for our patients with cholangiocarcinoma. I have the distinct pleasure of introducing Jennifer Knox from the Princess Margaret Cancer Center. She's a professor there, and she's the head of solid tumor oncology. She's been a force in our field for many years, and I have no doubt she'll be giving us a great talk.
Good. Okay. Well, good morning, and I'll echo the comments that many of my colleagues have said. This is really such an amazing meeting. Just not only just the interaction of sort of some of the best in the field, but the interaction with the patient and the caregivers. And I was just thinking, last time I was at this meeting, I went home completely revitalized, deciding I was going to put new efforts and more work and more research. And so this is really a wonderful opportunity. So I'd like to thank the organizers, Dr. Kelly and Dr. Bardizzi, for inviting me. It's a great honor. I also want to very briefly thank friends and colleagues who lent me some slides to adapt to this talk, which saved lots of time. Okay, so I've been given this interesting task of trying to integrate the new with the old for better treatment paradigms, which I think is a challenging topic, but on the other hand, I get to give this talk after everybody has presented and explained most of the topics, so I have that advantage. So as we know, and we've heard about so many times, biliary tract cancer is an umbrella term for several what are likely biologically as well as clinically distinct tumors. And we can define those differences by anatomy and histology and etiology, and now thankfully genomics. And so when we think about treating these patients and trying to improve outcomes, we have to keep all of this in mind. So philosophically, they say the world is divided into two general types of people, lumpers and splitters. And I think splitters think they're smarter because, well, if you can split up, it means you understand something better and you understand the science and biology better. And lumping is maybe a beginner's approach. But the point I'm going to try to make is that we probably need some of both of this. Katie's smiling at me. We probably need some of both of this so that as we make progress in a difficult cancer, we don't lose what we've already learned and we add to it. So a lumper would be one-size-fits-all kind of therapy. So you treat people with the same therapy and expect the same beneficial effects. So a very simple example would be surgery. If it's resectable, you should and safe, you should resect it. And then the splitters is more trying to look at what would be a treatment that based on the anatomy or the genomic profile, you could benefit that patient more than you could another subset. So throughout my talk, I'm going to refer to this plasticine approach. So here's an overview of my talk, and mostly it's going to be an advanced stage. So, and we oncologists, we tend to think in terms of lines, and maybe that will all change one day, but right now this is how we think. So we do have a standard chemotherapy, and thankfully the UK group established that for us back in 2010. And now there's a lot of studies that are directed at improving the chemotherapy or getting a better outcome. And of course, how do we interact or integrate the biologics such as the targeted agents and the immunotherapy that we're so excited about. Unfortunately, in the second line setting, so after standard of care, we've really struggled to establish a standard, and we don't have one yet. And hopefully, we're seeing some real promise in the biologics that we've heard about throughout this meeting. but we will always need more and more options because one size doesn't fit all. And then systemic therapy can cure more patients in the resectable, and we've already heard talks about adjuvant therapy. So kudos to the Brits again for setting a new standard of care in 2017 with the BuildCap study that Dr. Bridgewater presented earlier. So now that gives us some license to drop a control, no treatment arm on studies, but also try to improve on chemotherapy, ask questions about the role of radiation, and also where does biologicals fit into adjuvant care. So, improving chemotherapy in the first-line setting. So we all know this is the standard of care to beat, which was the ABC02 trial, which showed the improvement in survival with a doublet over gemcitabine alone. I think it's important just to point out briefly that if you look at the forest plot that has been explained by so many, this group here all seem to benefit from the chemotherapy doublet equally, and you can see that there's good representation of the different subtypes of biliary cancer in that group. So this is clearly an example of lumping. Now, there's other regimens that are used, the GEM-OX and the GEM-S1. They look similar. They're not as well studied as this, but many people accept them. Just a little comment, and I have a slight bias in this. I don't like to throw active therapies out too soon, and we did this review from my database because we recognize that there are patients that respond quite impressively to chemotherapy and continue to do so for a long time. Unfortunately, we don't know who they are at baseline, and largely this data was in the pre-molecular era. But certainly, we do have patients that do better and have a median survival, and we treat them sometimes with chemotherapy breaks off and on for several years. Now, just to take a slightly different approach, and it may not be quite as exciting as the new biologics, but one area that hasn't been really well addressed is looking at resistance to chemotherapy. And this nucleoside transporter, HENT, it's been known for quite some time that about a third of biliary patients don't express this transporter, and you need this to get gemcitabine into the cells. And then more recently, there's been a meta-analysis in both biliary and pancreas cancer, and you can see that in the plot that shows that this is a very good predictor for response to chemotherapy and longer-term survival in both adjuvant and metastatic settings. So while it's not as exciting as new discovery, it gives us an opportunity to try to optimize therapeutic indexes in treatments. So I've been interested in this drug along with the UK group called Acelerin, and basically it's a protide of gemcitabine that was designed to get into the cells, overcome all the resistance issues that gemcitabine has, and indeed that seems to happen. And the active moiety of gemcitabine, which is the triphosphate, is found to be at much greater levels in cells and leads to more cell kill. So with that in mind, and following a phase 1 trial in the UK in combination with cisplatin that showed quite remarkable response rates, about 50% in biliary patients, we're doing this trial. And essentially, we're going to copy the ABC02 trial exactly the same patient population, a lead-in randomized phase 2 to 3 design, but we're just going to substitute this drug in for gemcitabine with platinum compared to the same arm, comparator arm, and look for an improvement in overall survival. And hopefully if this works, it becomes a new platform of a better tolerated chemotherapy for patients. And I just want to show the front page of our protocol because it makes the point that we need international collaborations. There's lots of questions to answer. This isn't the only question around, but it'd be nice if we could all work together and get it done very quickly. So along with the Canadian group, we have the wisdom experience of the UK group joining us, as well as the Australian GI group and the ACRU in the US. So now, developments that have been ongoing are looking at what about adding more chemotherapy in, and looking at triple combinations. Is more chemotherapy better? And we've learned that FOLFIRINOX, which seems to have an advantage in pancreas cancer, seems to be too hard to tolerate. And there's some other combinations with adding in a fluoropyrimidine, which makes some sense, and we're waiting for that data. But perhaps the most exciting recent was this study from MD Anderson that showed adding the nab-paclitaxel to cisgem led to a fairly impressive PFS of 11.8 months, a nice response rate, and a median overall survival. So in a non-randomized trial, apparently well tolerated. So this is going to go on in a phase 3 trial, I hope, through the SWOG group. And we've also heard how it may be moved into the neoadjuvant setting because there was observation of some downsizing to surgery, which is important. So now what about adding targeted agents to chemotherapy in the first line? So that seems an obvious question. We have some history with this, and it's a little bit sobering. And so here in the past, all the talk for a while in biliary tract cancers was EGFR inhibition, and here is a listing of 4 different randomized trials looking at different EGFR inhibitors added to a chemo backbone, which unfortunately are all negative. There may have been a signal with response rate, but unfortunately PFS and median survival didn't pan out. And I think the lesson learned from this is that we didn't really have a biomarker selected population in which we could really choose who's going to benefit, because I think most of us agree there is some activity with EGFR inhibitors. We just haven't been able to prove it in a larger study. And then, of course, there's the VEGF inhibitors, and Juan Valle gave me this slide, and there's been 2 studies done. One was adding sorafenib to gemcitabine, was negative, and there's actually a signal of toxicity in which maybe adding the sorafenib led to less delivery of both drugs and a worse outcome. And then in Juan's ABC03 trial, with the addition of cediranib to cisgem, which is an oral VEGF inhibitor, there was some signal. Certainly there was a better response rate in 6 months, but the overall primary endpoint was not met. And to quote Juan, do we need a better VEGF inhibitor, one that's better tolerated? Because when you add these targeted agents to chemotherapy, you lose something sometimes in toxicity. So the monoclonal antibody to VEGFR2, ramucirumab, is underway with cisgem in a randomized trial. And this is the agent that, when added to chemotherapy in gastric cancer, actually improved survival and was well tolerated. So certainly, we look forward to hearing those results. Now, MEK inhibition, or the targeting the MAP kinase pathway, there's a lot of preclinical and clinical evidence of some activity of this drug, or this class of drugs in biliary cancer. We did this study a little while ago to try to acknowledge that there's probably a better way to sequence these drugs with chemotherapy. And in our mouse xenograft models, which are human cancers within the mouse, we found that if you stop the selumetinib before you give the gemcitabine, the cells come out of cell cycle arrest, go into active dividing again, and then the chemo hits them, as opposed to just combining them blindly. And we found in our tumor models that it worked much better. So with that, we leveraged this investigator-initiated trial, which I've just completed, which essentially tested that hypothesis in the first-line setting. So you either got your MEK inhibitor continuously with chemo, or you got it on a schedule where you wash it out before each dose of chemotherapy, and compared to a control line with the primary endpoint of a radiological response. So we completed accrual to this in the fall. I don't know anything about efficacy yet, but I can tell you without any doubt that this arm is much easier to deliver, much less toxicity, and this arm was a problem. So now, developing second-line treatment is very important. And rather than going over individual studies, and there's been a few, Dr. Lamarca did this nice review, which basically summarizes that with all these different studies, there really is no convincing evidence of a winner in the second-line setting. And soberingly, the median progression-free survival for patients in this setting seems to be less than 3 months. So we got a lot of work in this group. So following from that, the UK group are doing this ABC06 trial, which essentially is taking patients who've had prior CISJAM and then randomizing them to a full FOX regimen versus very active symptom management. And I can't emphasize this enough. We seem to take for granted that drugs are better, but I think in some situations, good supportive care, well management of their stents and everything probably prolong life as well. So you need both, and they have a overall survival endpoint. And I understand this is recruited, but likely not to report out until probably it matures in about a year. So look forward to that. Now, things got exciting a couple of years ago when we started understanding the molecular subgroups of biliary cancer, and this really launched a whole new approach. And so you're well familiar with this, but basically, based on exome and RNA sequencing, we saw that there were different, perhaps targetable areas in different parts of the biliary tree. And perhaps where most drug development has been focused has been on the FGFR2 fusions and the IDH1 mutations, which we've heard about in great detail, excitement at this meeting. And then very recently, this fabulous paper came out that now I think brings in whole genome sequencing combined with the ICGC cases, and looking at not only mutations, but copy number variations, gene expression profiling, and epigenetics. It seems that these cancers can cluster into 4 different groups, driven largely by etiology, which is fascinating, but also gives us a better idea of how to target some of these groups. Perhaps this one with immunotherapy, and this cluster 4 has the IDH1 and the FGFRs. And we're also aware that there is a difference in prognosis, which confuses a little bit our evaluation of how these agents work, but more knowledge is good. So with that, and just to summarize, it's incredibly exciting that we have 1, 2, 3, 4, 5, maybe there's more, FGFR inhibitor trials open now that include baskets and for patients with cholangiocarcinoma. So this is amazing, and there is some hope and expectation that in this very rare subgroup, that response rate may lead to some early approval of these drugs to get them to patients sooner. As we've mentioned, because of this prognostic versus predictive, do these patients do better in general, we will need some randomized trials, and they're, I think, probably being planned. And we've heard some fabulous data from Dr. Goyle about overcoming potential for resistant mechanisms, and maybe there's a way to tease out patients who could have very durable control on these drugs, maybe in sequence. And of course, if this is successful, this should move up the chain and out of second line into first line and possibly one day adjuvant. And again, to summarize the IDH1 mutation studies, I know of 3, there may be more, that are targeting this right now, which is extremely exciting, including a randomized trial, the Clarity trial. Probably maybe some further patient optimization might be needed, and we should learn that from the subgroups in the trials. And there's also the potential for the oncometabolite 2H2 as a biomarker of response, which is very exciting as well. So checkpoint inhibitors, boy, very exciting. So there's a huge rationale, and some of this has been discussed at this meeting for why this should be studied, given the etiology and the history and the liver vulnerability in these patients. And all of us, I think, remember the day we saw this waterfall plot first presented, where it showed the ability for a checkpoint inhibitor to lead to even complete responses in a cholangiocarcinoma in patients that have the mismatch repair deficiency, which is a rare subgroup in cholangiocarcinoma, maybe 2 to 3%, but we don't want to miss that. So that led to FDA approval for pembrolizumab in MMR deficient patients, regardless of the agnostic of the histology. And there is another trial, Keynote 158, which includes a variety of patients, a large cohort of cholangiocarcinoma, so we'll learn something about the microsatellite stable population in that as well. But there are many, many, many ongoing trials in the immuno-oncology space, not just checkpoint inhibitors, but many, many T-cell strategies and things. And so I really think this is a big part of the future. So now back to my lumper and splitter analogy. So in the lumping side, chemotherapy is established as an advanced disease in the first-line setting with survival and is the bar to beat. Now we're going to focus on determining better regimens, remain a question for trials, and we need to establish a second line. And I still imagine there's going to be a second line approach that will be for most comers as well. In the splitting group, certainly integrating local regional approaches to some select patients is very reasonable. But the biomarker-driven rare subtypes are leading all our interest right now, FGFR, IDHR, MMR, and others. And then we have to figure out how best to integrate those care plans into their histories. So let me take you through briefly. This is an approach. It's not the only one, but it's the way medical oncologists think today in our big centers to try to do the best for our patients. So it starts with an unresectable advanced biliary tree cancer that ideally has a good piece of tissue that has been sent off for tumor profiling. And I think as oncologists, we have to work a lot harder on making sure that we get that for everybody and overcome the barriers for that and get that going. So while that's happening, and ideally, back one. Patients should go on the standard of care, which is cis-gem, or at least the trial where cis-gem is the control arm because of this level 1 evidence and the survival advantage of that. Let's not forget that we do see downsizing of these patients to resectable, so we don't want to miss that opportunity. Maybe the tumor pulled back from a vessel, which opens up an opportunity for surgery. And certainly retrospective data sets suggest, especially in intrahepatic cholangio, that could lead to improved survival. Now, of course, if you, in that rare case where it turns out you have an MSI high patient or some other indication with hallmarks of HRD, you might want to change the plan early and go direct to a checkpoint inhibitor or an immunotherapy trial. Otherwise, patients get treated on till they progress or are intolerable, and again, I think chemotherapy should be optimized and get the best managed and get the best benefit from it. And then the profiling becomes very important, and oncologists have to figure out ways to access these trials for their patients, and with our networks and our various clinical trials programs. So FGFR fusions now, of course, you're rare, but you should go on a trial very quickly. I have the dotted line suggesting that maybe at some point this might be moving into the first line setting as these trials are planned. IDH1 goes to the trials. high neoantigens, or any way we want to define high mutational load, is probably a reason also to get onto immunotherapy sooner. And then we have these boxes where there's a lot of good hypothesis now, epigenetic targets like ARID1A, EZH2 inhibitors, and also known rare but druggable mutations should really get onto basket trials, umbrella trials, something in your institution or nearby, maybe your phase 1 group, something so that you can get access to these drugs. A lot of your genomic analysis is going to come back with no obvious targets, but that doesn't mean you shouldn't try to treat them and put them on trials with good hypotheses. And last but not least, let's not forget the importance of best supportive care for continuing quality of life and high functionality of these patients. And we couldn't do this without the multidisciplinary management of all the different kinds of doctors, nursing, interventional radiology, palliative care, psychology, and GI. And to Stacy's point, yes, I think if you can go to a center of excellence and at least get an opinion and a plan up front, it would be very helpful. How am I for time? Am I right? I'm not done. How much more? Okay, yep. So I'm just going to very quickly go through Adjuvant, and Dr. Bridgewater nicely summarized the BuildCap trial, which is a fairly large trial in Adjuvant. And as I said before, kudos for this improvement in survival. And despite the criticism on the statistics, I think most oncologists worldwide have accepted this as an improvement, and it's become a new standard of care to beat. We heard briefly about the French trial, which is puzzling because here a more active, stronger regimen of GEMOX was compared to surveillance, and yet this is a negative trial. Now, this speaks a lot to do with the patient selection, and perhaps it was a better prognostic group, but it still adds to controversy. Small trial. And then I just want to mention very briefly the SWOG trial, because many Americans may have been treated on this regimen, in which we combined chemoradiation with chemotherapy. It wasn't randomized, so we don't know what the impact of this was over a different regimen. But what is quite striking is that our one group, which John mentioned didn't do as well on the BuildCap study, seems to do as well on this chemoradiation protocol as the R0. So that is very intriguing. And it was safe. So that brings us to this protocol that Anthony Alqueri and myself have been working on with the Hepatobiliary Task Force with Ghassan Abu Alfa. And we hope that this is going to get launched soon, maybe, and have a lot of support. So basically, we're asking the question, can we intensify chemotherapy, so GemCap over cap alone, and get a better outcome in the R0 group, and also recognizing that maybe about a quarter of our patients will be R1, and they're not going to do well on a control arm like cap alone. So they go right to GemCap, and then are randomized of the importance of radiation. So we hope this will get going, and one day will advance the field. I just want to point out really fast that targeted agents in adjuvant is controversial. So briefly, this is a bunch of recent trials with molecular targeted agents in lung and kidney cancer, with really well-established molecular target agents in the metastatic setting with clear evidence of benefit, and yet, unfortunately, largely negative and quite controversial outcomes. So why? So we need better understanding of our biomarker again. So back to lumpers and splitters. Adjuvant chemotherapy, I think, has been established, and now we need to improve on better regimens. And in the splitter side, chemoradiation makes a lot of sense, I think, in R1 patients, and we need to prove that. And we need to think that these biomarker-driven rare subtypes will eventually come to an adjuvant setting, but we're not ready for that yet. So therefore, to wrap up, I think we all agree this has been an exciting year for cholangiocarcinoma, and much progress has been made. And we now have a survival advantage with a simple tablet in after surgery, and now the leverage to do more studies. And to John's point, we should do these studies a lot faster and collaborate and get them done. In the first-line setting, a lot of studies, a few of which I've mentioned, which are trying to get a better therapeutic index and outcome for first-line patients. And we really do need to establish probably multiple different second-line therapies for the different subgroups as well. Bench to bedside and back again is probably the order of the day, and Dr. Goyle's work is a fabulous example of that. We need more of that. And then, as I've said before, we can't all agree maybe always on the exact question, but I think there are many good questions and we should collaborate and get the work done faster. So I think that is really starting to happen, and meetings like this help us. So that's me. I'll leave you with my favorite cartoon. I think those of us who treat this disease and those of you who come to this meeting and support us, you are in the optimistic fish category, which is me. Thank you.